afternoon all. Welcome to today's session as part of the Lady Amalia Fleming Lecture series. Thank you for joining us in what will undoubtedly be a reflective and eye-opening afternoon with Dr. Sbaiti. Today's session follows the recent UNESCO Global Education Monitoring Report titled Women Lead for Learning, which focuses on barriers to gender equity and equality in educational leadership. These barriers perpetuate the well-established XX paradox, which refers to the gross underrepresentation of women in all global health leadership roles, education included. As founder of the Children's Defence Fund, Mariam Wright Edelman states, "You can't be what you can't see." Here at the WHO Collaborating Centre, we aim to cultivate a positive space for aspiring women leaders in STEM by creating this platform for a diversity of women in medicine and public health leadership to be seen. So this series has been inspired by the incredible work of Greek physician, author, resistance fighter and socio-political activist Lady Amalia Fleming, who amongst her extensive list of achievements was a pioneering woman in STEM. So very fittingly then, it is my pleasure to introduce Dr. Mariam Sbaiti, a senior teaching fellow in global health and the newly appointed director of the intercalated BSc in global health here at Imperial. Today, Dr. Sbaiti will be delivering her lecture titled Reflections on the Curriculum: Why is the Global Health Classroom an Important Space to Study and Reimagine Global Health? After the lecture, we'll be going into our She Leads section, where our co-director Celine Tubj will be interviewing Dr. Sbaiti and on her journey being a leading woman in STEM. So without further ado, I will hand over.
Thank you very much, Nishani, and thank you to the whole WHO collaborating team for having me today. It's a real pleasure to be here and to be part of the conversation, and especially special to be introduced by one of our alumni from the Global Health BSc as well. My name is Mariam Sbaiti. I'm a senior teaching fellow in global health. I, as Ishani mentioned, was newly appointed to the Global Health BSc as a director. I have been working on that on the course since 2010 when I joined Imperial, so a very, very long time. And since I joined Imperial, I've been kind of reflecting on how to do global health education well with all the constraints that might come with the role of global health education. So my title is a little bit wordy, but what I'd like to do today is to argue that there's a role for global health education to engage with the wider world, and what we do in the classroom needs to be basically the pedagogical approaches that we take in the classroom need to be informed by what we know about the inequalities in our field and in the education sector, but also that as a space for inquiry, the global classroom is actually a really productive space. And this is something that I was become really excited as I've done more work in this area. So let me share a little bit about me and then some of the kind of early reflections that came up in my work. I didn't know who was going to join today remotely, so I thought I'd just have a very open introduction about what do I actually mean with global health education. And when I think about my team, what we're really busy with a lot of the time is basically delivering teaching. Anyone who's involved in teaching knows that between being in the classroom and delivering assessments and marking, this takes up a lot of our time. A lot of our time is also involved in curriculum design. And then at the core of, I think, of our roles is the governance of our education work. I've just come out of a meeting with our external examiner. I'm an external examiner myself at LSHTM, and the leadership, both at kind of course level, but also more strategically within the school and beyond in our sector. And at the end of the week, we might be able to have a little bit of time for professional development, which is, I think, an important part of it. So, for example, a few years ago, I completed my Masters in Education, and some of the research that I started within that is some of the work that I'll be talking about here. This is our latest cohort of Global Health BSc students at our Christmas due last term. And so I work within the undergraduate education team within the School of Public Health. So I've also been involved in other work such as medical education, undergraduate medical education, or postgraduate, some of the postgraduate work that we've done here, that we do here at the school. And the reason why I've put all of those arrows is because actually part of the presentation today, what I think very much is these three ends of the triangle as kind of informing each other, and I think that's where the work of global health education, or education in general, can become quite creative and dynamic. So as I was preparing my talk, I was thinking back to my time as a new educator in 2010 when I first joined the School of Public Health, which was partly based at St Mary's, and I think I'm right in saying that I was the first teaching fellow, perhaps, in the School of Public Health, which was quite an interesting position.
We founded the school.
Sorry?
This is the year that the school was founded.
Right. Okay. So yeah, they were very much. So when I reflected on putting this slide together, what I realised is that my position today as an educator is so much different because we now have lots of teaching fellows in the School of Public Health, and what that means is that there's a community of practice. There's many of us who can share feedback, share scholarly approaches. Many of us have gone on to do a master's in education, and I think that really creates more possibility for growth. But what I did have at the time already, and this is why I stayed in the job for so long, was that I became quickly very passionate about my role of learning as an educator. And I'll come back to this idea of learning as an educator as something that relates to critical pedagogy as well. Today I'm still learning as an educator, and some of the work I've done in researching my students' experiences has been quite humbling actually, and very much still a learning process. But as I said, I'm well surrounded with a community of practice, and with, I think, a group of people within and beyond Imperial that are kind of interested in asking the same difficult questions about our field. So, in those early days of teaching global health at St Mary's campus, I remember having a sense of excitement, but also a sense of responsibility. And I remember thinking through this idea that there's something about what's happening in the classroom, and then there is the bigger context of inequalities, which I'll come to talk about, which Ishani alluded to in the introduction of this talk. And the reason why I've got an office door on my slides is because a lot of these reflections happened behind my office door. This was not my original office door, by the way. This is very much a Google office door. Yeah, so like I said before, what I'd like to argue today is that actually over the last few years, for me, it's become very clear that teaching global health requires, it absolutely necessitates engaging with the wider inequalities in our sector, and that we can get a lot of really useful empirical data from our classroom. So, some backgrounds on this context that I'm talking about then, in global health education. So the early 2000s saw a real explosion of global health degrees worldwide, which created opportunities for people to get involved in the field. But as an educator, one of the first pieces of data that really struck a chord with me was the inequality in the geographical location of master's degrees in global health. As you can see, this is a paper published in 2020, so the figures may well have changed. But as you can see, 95% of these degrees are actually based in the US and North America, and Europe, sorry. It's not just difficult for candidates internationally to reach these because of visa hurdles or because of the cost of living in those cities, but also the average tuition fee charged was $37,000 at the time, with an average of $68,000 in the US. And for programs in the UK at the time, actually, the international students were paying 25k in US dollars, but I know that at Imperial now we're charging £45,000 for international students. So this really, to me, depicts the incredible barriers that there are in terms of accessing education and therefore progressing into a career in global health. But beyond this, what's included in the curriculum is also potentially troublesome and problematic. So some of our colleagues in the Global Health BMJ argue that power asymmetries are reinforced through the education system, so once one is in the education system. And Emily Kumbesson wrote a decolonial guide to global health research, and really sort of argues around how knowledge production via high-income countries dominates education curricula. So there are different levels of inequality within our sector. And this data, I think, really kind of stands out in comparison with, or contradicts the kind of aspirations for reciprocity and equality that are often called upon in the global health field. So I'm always fascinated by things that are in contradiction with each other. Now, the authors of this paper suggest a couple of different explanations for why this might be. One is that potentially global health training as such is a concept that is culturally specific to high-income countries. So, and I'll come back to this, but the idea that often there's a famous definition of global health, and kind of sort of a debate around it, if you like, around global health being basically public health somewhere else, and a lot of people will recognise that if what is studied on a curriculum in a global health masters may well be what is studied in an everyday public health degree in low-income countries, for example. The other explanation is, of course, that degrees are revenue generating, and this is the case in Imperial as well. So this poses questions for us as educators on a range of levels regarding who accesses our courses and then what we do once students have access to them. And this is just really reflecting on what Shani already said, but the latest 2024 Global Health 50/50 report shows that out of the non-profit board seats that were held in global health, 65% of these were held by nationals of high-income countries, and only 5% were held by nationals of low-income countries, which is quite shocking given the conceptual focus of global health on low resource settings. And another really important figure here, I think, is the fact, particularly for this lecture, I think is the fact that 2% of seats of non-profit boards were held by women from low-income countries. And we know that women from low-income countries are basically the majority of the healthcare workforce globally. So this is a really strong asymmetry. Now, there's been huge advances since the last report on gender equality, but it's taking an intersectional view. Actually, it's really concerning that that 2% figure is still the same. So this is my first invitation for a reflection, and my second one will be, in my second one, right at the end of the lecture, I'll invite you to dream about what global health might be in 10 years' time. But for now, imagine that I'd like to invite you to imagine that you're tasked with designing a module titled Global Health Challenges for a Masters in Global Health at your local university. So wherever you're sitting, your local university, this may be here at Imperial, or maybe it's your local university where you live. The term starts in a year's time, and you have a small budget equivalent to an educator for 1 day a week. not sure how realistic it is these days, because I've not closely followed a new program being set up for quite a few years now. What steps might you take to ensure the course is designed and runs successfully? So anyone here in the audience, but also those of you who are joining online, please feel free to share in the comment box. Any particular thoughts on considerations that you would take to design a course from scratch?
Would we have access to talking with previous participants on the course, and then maybe prospective students on? First thing would be stakeholder engagement for me.
Yes,
so just looking
okay.
at what stakeholders I have and try to talk to them as much as possible.
Great.
Yeah.
So students as stakeholders,
Yeah.
and thinking of what do people actually want to learn?
Yeah,
what do people want to get out of this?
Yeah.
Yeah, brilliant. Yeah. Any other points?
Probably contacting somebody on the ground where you're planning on the students going to work in the future. So
Yes.
what is it, rather than a top-down approach of what we think they need, what they actually want from all these white saviours swooping in into their countries and on the global health field, rather them tell us what they need rather than us tell them what we think that they need.
That's really interesting, actually. And so, are you thinking then that the who are the beneficiaries here? Would you be engaging with beneficiaries? So let's say we're doing it at Imperial. Who would be the beneficiaries?
So I guess we really need to find a target audience.
Yeah.
So maybe find out where the students plan on going with their global health.
Yeah.
And then find a suitable target audience to kind of. So maybe you could get someone who's doing a masters to actually do this for their project.
Yes.
There must be earlier stage on this literature, which is basically I need to study what are these global challenges. So I need to research at least if I don't have the knowledge and the capacity to have the big picture about global health. But then I go and do some research. Or if I can't do research, I ask an expert what are the challenges.
Yes.
Something
So
like
actually, expert opinion is really useful as well, and the literature, of course,
to me,
because
this
it
is the
is.
starting point.
Yes, great. So
Especially within that small budget.
Budget,
Yes,
yeah, the budget's
yes.
a problem.
Absolutely. Well, yes,
Maybe
absolutely.
you could use the budget to pay for somebody in the global south to do the research for you.
Yeah, because
Right,
you need
yes.
an epidemiologist, definitely.
I'm-
You need epidemiologists to look at the global health. So maybe get an epidemiologist to teach on the course.
No, I'm really liking this brainstorm actually, because and I was wondering if anyone online has any thoughts as well. So please let me know if there's any more comments. But that's really interesting. Thank you for that. I think definitely engaging with the literature and with what the literature says, because it is an academic program. I really love the idea of stakeholders, and absolutely, I think it's one thing that I'll come on to talk about in a minute. And with the stakeholders beyond us, and who is your the population that should benefit from your work and expertise. I think that's a really important point, and something that Quentin Eichmann talks about in some of the future slides. So I'm going to be coming back to that. Do we have any comments from?
Mary,
Yes.
may I have one point? You see, conceptually, when you talk about global health,
Yes.
you need to. There is a philosophy here.
Yes.
You need to say that health is global.
Absolutely.
People need to understand, and this is what we produce a document many years back. Go and see it. Department of Health.
Right.
Nick Bennett-Vale, I, and a few other people produce a document which is health is global. And unless we understand that health is global,
Yes.
we cannot understand global health.
You've actually just preempted my next slide. So I was just going to say, I've talked all this time about global health and global health education, but I haven't actually defined global health. And so I thank you, because I will go back to that reference, Salman. It's a very welcome reminder there. And for me, and you may or may not agree with what I'm going to say here, but for me, the definitions of global health became interesting when I started teaching global health, because like you said, I wanted to define what we were doing. And one of the definitions that I used a lot in my first couple of years was the Kaplan definition published in the Lancet, which defines global health as an area of study, research and practice that places a priority on improving health and achieving equity in health for all people worldwide. And this definition really stayed with me. But the reason it stayed with me wasn't necessarily because of the contents, but it was rather the making of the definition which really stayed with me, and I'll tell you the story in a minute. As a definition, I find it, personally from my perspective, I find that it's a fairly normative definition. It assumes that all the actors in global health are aiming for equity, which is, I think, more of a political value. It's a value, it's an ethical, political standpoint. So when in the classroom, I tend to encourage my students to think about unpacking this kind of definition. But soon after I started teaching, I also read an ethnography by Joanna Crane, which is referenced below here, on the Consortium of Global Health Universities inaugural conference in 2009, and this is when this definition was put together in what was supposed to be a collaborative common exercise. This is supposed to be a common definition, and it was supposed to be a collaborative exercise with several delegates from around the world who attended that conference. What was really interesting is that Joanna Crane, who was sat in the meeting, actually did an ethnography of the kind of interactions that were going on in that meeting. And what transpired was that this final definition didn't actually take into consideration the objections of quite a few Global South delegates there. There's a really good quote by the, I think, Dean of the Bangladesh Medical School, saying, well, what you're calling global health, for us it would be nursing, or it would be public health activities. The only reason why it's not called global health in Bangladesh is because it doesn't receive international funding. And I think those were really important conceptual contradictions that were kind of marginalized in the final kind of publication. And for me, this is a real story. This is a story that really stuck with me because it's such a symbol, a strong symbol of the kind of discussions and also the conceptually fraught nature of our field of study. I will come back to another definition of global health later on in the presentation, and one that I offer for you to have a think about as an alternative. So then, if we are going to design this module for the global health challenges, how might we start? So we've had some really good suggestions in the room so far. In terms of whether we could go, for example, for prerequisite standards, there is actually no prerequisite standards for global health education. I'm speaking to the experts here, and you may contradict me, and you may think that actually it's different. But to my knowledge, there is no prerequisite standard for global health education, and there is a fair amount of variation between different degrees, as opposed to public health accreditations. For example, in Europe we have the APHEA, which accredits public health programs. There is a toolkit, again published by the CUGH, which is a really useful one because it lists a range of competencies which can be really useful for people setting up a new degree ex novo, but also it's a free toolkit. It can be used for comparative work between different curricula. It has been critiqued for being quite kind of knowledge heavy, so it's sort of focused on acquired competencies, which can be sort of assessed independent of context, rather than participatory ones, which are more contextual and based on aptitudes. So I did look this up, and the third edition of the toolkit is essentially still very much representative of high-income country authors. In fact, there's a really large number of people from Texas who wrote this toolkit, which isn't interesting. So Texas definitely showing up in force for global health in that one. So yes, a range of kind of limitations around the toolkit. But one thing that that to me stands out in the kind of discussions around public and global health education is that the public health field, through particularly the reckoning around the Black Lives Matter movement, has moved towards recognizing the importance of systemic oppression in health, and this has been kind of validated also through different kind of research methodologies. For example, incorporating intersectional approaches into more quantitative work. But this hasn't really translated into education. And Anushka Akhil and colleagues did some really interesting work at Johns Hopkins University on kind of different approaches to pedagogy in public and global health. And what they argue is that actually public health graduates are not, they are trained to learn about the importance of systemic oppression for public health, but they're not necessarily learned to prepare to address that. And that particularly involves skills and aptitudes around reflecting on your own position in society so that you can address and intervene. This particular reference responds to Rachel's point about the the different types of competencies. So at Imperial, of course, with the new Science for Humanities strategy, we have a very ambitious educational mission to prepare graduates to tackle complex real-world problems. And 4 out of the graduate attributes at Imperial focus on skills and aptitudes around cross-cultural work, collaboration, and developing a professional identity, which are all things that require actually a fair bit of reflection and engagement with reflexivity, essentially. So IFAM is very much argues for more participatory, more kind of contextual, aptitude-based teaching in public and global health. And he also actually really advocates for assessments to actually involve markers who will be the recipients of the work that our graduates will be doing. Which I think is, when I read about that, I thought, gosh, that changes our whole mindset. I haven't quite figured out the implications of that or what that might look like, but yes, I thought it was a very interesting suggestion and really productive one, probably. So I've given you a whole load of complications about what it might mean to be a global health education, and particularly a global health educator within a research-intensive university in the UK, which is very much what this work is talking about. The inaugural chair of the Public and Global Health Department at McGill University, Prof. Madhukar Pai, is very vocal on issues of allyship, and he published an interesting paper in The Lancet advocating for shifting power in global health and saying that what is needed is leadership from global south actors and allyship from global north actors. And he goes on to outline what each actor in global health can do. So I've reproduced the row in his table that pertains to academic institutions. And I could really finish my talk here in some ways, because I think that these are the necessities in order for our sector to make more sense, given the inequalities that I've outlined before. Madhukar Pai basically puts the emphasis on reducing tuition fees for trainees from low and middle-income countries, offering scholarships, building equitable and bi-directional partnerships, ensuring reciprocity, and host trainees and experts from low and middle-income countries, and change tenure and promotion criteria to acknowledge allyship. And there's a really interesting paper by Daniel Krugman that just came out on how the implicit incentives in funding for global health in a US institution are so tied up against allyship practices. But I did actually reply to this post on social media, and I hope that maybe if Madhukar Pai publishes another paper with this table, maybe he'll include some of the work that he's done and some of the work maybe that we've done as well on the content of global health pedagogy. Because I think next year this autumn we'll be running another iteration of our global health courses. And whilst global health education is still located very much in the global north, what can we do within the confines of our classroom and a little bit beyond it. So like I said, I'm going to be moving on to describing 2 curricular innovations which we implemented on the Global Health BSc, which then also were taken up and implemented at postgraduate level and also in other settings, and then also some research experience on our students' experiences, which basically have informed more of what we're doing now. So, I think I mentioned earlier about sitting behind a door. I think I forgot to mention why the door was there. The door was there because I had a realization that as I was sat behind that door, I felt very excited about teaching and putting a curriculum together, but I also felt a level of responsibility. And it was me putting that curriculum together. And just like Rachel was saying earlier, who are the stakeholders? It felt like a lonely exercise. And so, you know, in those early years, and still today, the curriculum is still, in some ways, written behind a closed door. So one thing that I tried doing a few years ago with my team was to draw together the stakeholders and to redesign a small part of our curriculum on the topic of humanitarian health. So we gathered a round table of colleagues with lived experience of the Syrian curriculum. This was before the fall of the Assad regime, which happened literally 3 days before our students submitted their assessment on the Syrian conflict this year. And the difference with other approaches that have been taken in other universities is that so during the COVID pandemic, a few of our colleagues started to involve colleagues from around the world to teach on their global health courses. And that in some ways opened up possibilities, right? Because we started to become aware that actually, because we're teaching virtually now, we could actually just invite anyone to speak on our course. And this was very much, again, Magic Harper was very much at the forefront of that, and he still runs a short course, which is possibly the most global course I've ever heard of, that is global health. But those experiences tended to be around inviting guest speakers. What we wanted to do here was to not just invite guest speakers, but to have a team that would co-design everything, from the intended learning outcomes to the curriculum, to developing the curriculum and then delivering the curriculum, and then designing the assessment. So going back to Rachel's point, what do we need to teach? How do we need to assess our students around this? How do we even ask them the right questions? And then the marking and the module evaluation. So it was a fuller cycle, and so the idea was very much to, instead of having this kind of traditional status quo curriculum design process with the academic providers, we involved stakeholders. We also involved methods experts and students, so we got some funding for Student Shapers to bring some additional partners into the curriculum. And as far as I know, this model has now been used on the postgraduate Global Health Challenges module, and it's also been used in a couple of settings in Kenya and in King's College, I think, for the design of educational modules. So it's interesting because I think it just, for me, it felt like a really exciting experiment. And and even when we got it wrong, because we did get it wrong, it was a big team and we were short on resource because it's so much more time consuming to do education design this way than just sitting down behind a closed door. There was something that was tangibly valid within that process. Bless you. And this is one of the pictures that I showed you at the start of my presentation, which I forgot to say, it's one of the moments that I'm really proud of every year in our classroom. In fact, this was in this very classroom. So this is when we do a Q&A with Dr. Zahid Katurji, who is the protagonist of the For Summer documentary, which was shot by his wife during the siege of Aleppo. He was the A&E doctor and the hospital manager of the last standing hospital in besieged Aleppo. So that is a documentation of their life in extreme conditions with a baby, essentially sort of, witnessing and experiencing attacks on healthcare and war crimes, and resisting that. And I think when Zahid comes to the classroom, it's just really one of the most special days of the year, because our students, there is a real sense of connection in the classroom, and our students show up fully for that. And in fact, there's some research done by one of our students this year, qualitative research by a student who researched her peers' experiences. And what we're finding is that this type of teaching it enhances learning, because it's something that, there's a quote later on, it's something that students will just find so much more memorable. But also, interestingly, it had an impact on students' sense of inclusivity in the classroom, and as sort of almost a sense of moral obligation, but a positive moral obligation to be there, to be present. So I found that really, really fascinating as a journey to go on. And Dr. Labara, who's a scholar and a consultant in infectious diseases, has basically been co-leading on all of this work. And at the top right is Mervat Al-Hafar, who was working in Syria as a pharmacist, and shares a sort of human library session as part of our curriculum. The second curricular innovation that I'd like to share involves working with another set of stakeholders. This time it's stakeholders who are literally just around this building in the area of West London. And this year we had 5 civil society organisations in West London that collaborated with us to essentially deliver an experiential learning module for our students. So our students learn about local health inequalities and action, first in the classroom, and then they start visiting their allocated civil society organisation. And again, this is one of the bits of work that I'm so proud of for my team to have achieved, because given the contradictions, the conceptual contradictions of global health, the idea of looking out the window and saying this is global health in London, where inequalities are so stark, feels like it's almost a priority, and one of my highest priorities now as an educator. So one of our partners is the Young Brain Foundation. We've been working with them since the beginning of the CGP module, and what they do is they work to support the civil society sector around young people and children's welfare in Brent. Brent is one of the most linguistically diverse councils in London, and in the UK, sorry, and it's also one of the most deprived councils. And so what Young Brain Foundation do is essentially really important work that fills the gap of the funding cuts and the government funding cuts. And I'm really proud that we've also got another level of collaboration with Young Brain Foundation, because one of our PhD students, Fatima Sharif, is currently doing an ethnography of our relationship and this partnership. So it's a critical look at what it means. So we say we're doing great work, we're involving civil society partners in co-developing and co-delivering global health education. And Fatima, I hope, is definitely taking a critical look at this and exploring what that actually means, because there are different academic programs in the UK at least which are taking a similar approach. But of course, with all best intentions, we may still, it is a very complex partnership to be maintaining. And this is particularly true given that each organisation that we're working with is under increasing financial pressure, and therefore the kind of reciprocity takes a long time to to work on, and it takes time to actually ensure that it's a reciprocal kind of partnership. So this again is it's a way of teaching global health that is again takes more time in the holding of everything and the coordination. But the results have been really impressive, and this is that you can see a photo at the top of our yearly Impact Afternoon, where our students present the work that they've jointly done with their CGP partners. And Ashani, you would have been doing this a few years ago. So why do we do this work? Well, for me, local geography sort of speaks a lot about spaces, and I don't know why these are appearing automatically. Anyway, so for those of you who are not based at White City, who may be online, the underground. The underground symbol is where White City Station is located, and the red line is our walk into this campus, which takes about 7 minutes. 2 minutes into that walk, right in front of you, if you take the same route as I do in the morning, you see the remains of Grenfell Tower. Grenfell Tower, sorry, I don't know why this is doing this. Grenfell Tower, for those of you who don't know, the background was a social housing tower that burnt down a few years ago, killing 77 of its residents. And it's a visual symbol of the stark inequalities, but also the neglect of social inequalities in London, including, of course, with fire safety. And to me, it strikes me that we are in a local geography that has a lot of these symbols. So this is another view from my morning walk into work. It's an advertisement for a luxury flat with a swimming pool on the roof, and it's right outside White City Station. And thinking of this, and then thinking of the work that the civil society organisations do with our students, I feel that I'm in the midst of global health, actually, because this is what global health is, when we are right in the middle of these inequalities. Sorry, I'm still struggling to stay on my slide. And one of the most powerful moments for me around our CGP placements was when a colleague from Young Brent Foundation came into the classroom to teach students about the risk around the basically violence affecting youth. And he shared his own lived experience of entering a gang, being involved in gang violence, and then coming out of that and securing a job with Young Brent Foundation. And I think again that learning, particularly for us Londoners, or those who live in London for a few years, having to reckon with what some people call an epidemic in knife and gun violence, seems like one of the most. I would like to see that being framed in global health journals as a global health issue. So a few years after reading Crane's ethnography, I was completing my master's in education, and I became, again, interested in turning the lens inwards into our students' experience. I don't know how I can stop this automatic. If anyone has a trick, do let me know. I think I've paused it there, but yeah. Yeah, okay, thank you. So I started, because with the awareness of the inequalities in our sector, I was interested in how that might impact our students' experience. And I thought I was a fairly open door kind of educator, that I had a lot of conversations about what was going on in the classroom with students. But what I found out through my research was actually beyond what I'd heard, and that's what I found so fascinating about qualitative research. So we set up a study which later on then also involved a student from the Global Health BSc interviewing her own peers. We had 14 current students and alumni from the Global Health BSc, and we really just focused our discussions in a quite open-ended way on experiences of inclusivity. So, did you feel included in the classroom? Were there any? How did you feel around different lectures, different talk material? How did you feel in relationship to your peers, etc. And oh, don't worry. Yeah, I'll stop joking. Amazing. I'm just going to jump to the next slide. If that's all right. Thank you so much, Lily. Yeah, sorry, to the next one actually. The strongest finding of this study is that all 14 participants, which included minoritized and non-minoritized students, irrespective of their identity, sensed a sort of tension around the way in which communities were discussed in the classroom overall. For some students, this was kind of discomfort, alienation. For other students, it was a kind of, oh, there's something that doesn't feel right, perhaps in the language. But essentially, there was a sense of othering in the way that communities in global health were being discussed in the classroom. And interestingly, that then had an impact on inclusivity in our classrooms. So it wasn't just important in terms of the validity of how we teach, but also in terms of the sense of belonging and mattering in the classroom. And sometimes students would actually not turn up to class, or they would perhaps stay strategically silent when there were discussions in the classroom. And this for me was really important because at the time when we got these results, the curriculum review had come in and we had suddenly had a lot more validation for active learning approaches, discussion-based approaches. But with these findings, I actually had the realization that active learning may actually be quite exposing, that if it's not well facilitated, then it may actually be more alienating for a lot of students. And what for me was also worrying was that those students with lived experience of minoritization would kind of sometimes feel outsiders. They would also feel othered from the curriculum, and this was particularly with students whose lived experience was reflected in the curriculum. So there seems to be something tangible here that needs to be kind of surfaced. And another big part of the experiences of belonging and sort of inclusion in the classroom came from identities and relationships with peers. There was really something that almost every participant who talked about dialogue talked about this importance of dialogue, of almost shared values around having open dialogue. Do my peers understand that being able to discuss challenging topics is a good thing in itself, and that we will try our best to show up and respect each other's points of view? And when that didn't happen, students would drop out of those conversations. And this is a particularly positive experience from one of our students. I felt like there was nothing that we couldn't discuss. It was just very open, very honest. It made light of some essentially serious issues. And this was a student that had experience of being kind of cast as what she called an angry brown girl in previous spaces in global health education. So there was a sense that global health education could be particularly empowering, and for some of our alumni, it actually meant some of them employed a kind of sociological language around social capital, and sort of explained how actually they felt more empowered to make change in their future careers, etc. But the other side of that is that some, as I said, felt very excluded, and for me, particularly the absence of students in the classroom was a real concern. So of course, these findings were kind of encouraging and worrying at the same time for me. And one project that came out of this was, first of all, based on the idea of embracing tensionality. So tensionality is a term that was coined by Japanese Canadian educator Ted Aoki, and it refers to the sense of tension that can be found in any educational setting, particularly when it's affected by inequalities, whether they are racial or other inequalities. And therefore, his recommendation is for educators to not try and ignore it or just push it away, but to engage through pedagogy with intentionality. So to say to students openly, and this is what we do in our classroom, to surface that tension and to almost expect it, but also use it as a potential learning opportunity. And this is where I think it's particularly productive and exciting and transformative. So we now have a new curriculum and a new curriculum development toolkit, which we developed with 3 student shapers from undergraduate and postgraduate courses. And some of this content has been delivered on both undergraduate and postgraduate teaching. On the BSc, it's particularly well developed because we're trialing it out. And we start in week 1, so we start straight away. We aim to support students in engaging them to create their own supportive and reflexive learning space. We use a student learning contract to do this, and the students kind of collaboratively write the learning contract right at the start. And we start on Monday mornings with, I should put a picture up, we start on Monday mornings with what we call a Connect and Expand weekly session. And that is basically a session that is student-led, and the idea is to center student learning before our guest speakers come in. So that we start on a Monday morning with basically student reflections, and they take it in turns, students take it in turns to present to each other. Now, I'm almost at the end of my presentation, and I'd like to offer another perspective on global health definitions. Shea Abimbola, Prof. Shea Abimbola, the former editor of the Global Health BMJ, recently published a book which is a collection of his essays, so you may be familiar with some of this from previous publications. He describes global health as always involving working at a distance. And he says public health shares some of that characteristic as well. And when he tries to define global health, his approach is to say that it's actually the distance and the gaps in knowledge that come with that distance that defines global health. So it's the distance between those who are actors who have the power to make decisions in global health and the supposed beneficiaries. Now, his personal position is that these fields should seek to eliminate such distance, but what this definition does is that it allows us to look outside the window and consider West London to also be a space where global health happens, because as Shea Abimbola says, the distance is not necessarily geographical, but it's also a social one. His critique goes further than this in the sense that he defines the global health field as it is from a kind of descriptive standpoint as having a clear bias for technical solutions, but at its root, inequality is not at any scale a technical problem, but it's rather a political one. And I certainly, when I came across Shea Abimbola's work and colleagues, I found that this kind of conceptual approach to defining our field of global health made a lot more sense. And for me, there is something about distance in education as well, and the data from our students also speaks of that distance, the othering, and the distance that can sort of almost come into the classroom as a result of how we talk about communities. So then my story is very much a story of almost in a STEM-focused university where we don't have many social scientists. Almost coming to critical pedagogy via my students' experiences through qualitative work. And I think I've mentioned Ted Aoki here before. I was at a symposium this morning with Mohammed, and my colleague actually put a much better photo of sorry, no, that was, sorry, rewind, it's not Ted Aoki. But you have heard a lot of this content this morning. So yes, I've talked about sort of Ted Aoki's position around intentionality and sort of the implications of that. And for me, some of the other work that I then discovered that really resonated with my early reflections on all this was the other works of critical pedagogues around Paulo Freire's work, for example, Bell Hooks' work. And what I really like about Bell Hooks is her insistence on the presence of everyone being acknowledged, which really resonates with some of our students' experiences as well. And she says further to that, it's not just that it should be acknowledged and stated, but it should be demonstrated through pedagogical practices. So how can we design our courses and how can we deliver them so that every student brings themselves to the classroom and knows that their presence is valued? And this is something that I find very exciting and hopeful, particularly when sometimes we do sort of feel constrained with the realities of kind of everyday teaching. So now onto one of my final slides. I'd like to invite you to reflect, I think this is a reflection number 2, on, and I don't know whether anyone here or online may have a dream for global health education, but what, or even a hope, what would you hope for education, a global health education, to look like in 10 years' time? What do you think, and regardless of what may be possible, but what would you like, what would you wish for our sector to look like? Feel free to share, and people online as well.
Again, but it might be too futuristic, or I watch too many sci-fi movies. It's
the good sci-fi.
yeah, good ones. Yeah. Putting on a VR set and doing the changes that you learn to a community that I can play around with.
Well,
Is that the right word?
Sims, basically.
Yeah, like Sims, basically. But
Yes.
to like put that and see what I can do in 10 years if I implemented some prevention strategy.
So being able to access simulations around public health and global health interventions. Yeah.
And it doesn't have to be like this fancy set. I went to a lot of conferences and talks that it doesn't have to be this elaborative headset. It can be just a smartphone and then just some glasses on. But the software is there.
Right.
Kind of, because it is in 10 years, so I don't know. In a year maybe that might be possible.
Yes.
But it's just seeing how what we learn can actually affect the people around us and that community that you're talking about.
So to almost harness the technology to learn accountable, to be accountable.
And it's not
think
just
of your-
theory anymore, it's just seeing the practicality of everything. And I just wanted to mention even in 2024 WHO published a global health competency framework that does a lot of practical, what you mentioned exactly. So it's moved away from knowledge competencies and it
I
moved
forgot to mention that one. Thank you for bringing it up.
behavioral and practical activities into curriculum design.
Yes, great. Yes, thank you for mentioning that. Yes, absolutely. And that's well worth a look out for. I think we should talk about the VR headset. Yes, I like the idea of harnessing technology.
It's just seeing the effects, because even talking to students, I have a nutrition background, because even when I talk to them about behavior change or how can we learn to do something differently, they always say it's either monetary, that you can have to pay them to do some certain change in their diet, for example, or that they see the effect on themselves in a few years.
Right.
So it has an impact to see and it making that seeing thing more accessible. That would be kind of a good way for education.
So using visualizing it. So I know that VR headsets are being used within Imperial already in some teaching. I didn't expect that we would be kind of seeking to follow that, but actually maybe I've just changed my mind now. So thank you.
So less high tech, but maybe some more indigenous voices. Being that I'm from New Zealand, and when I've been studying, all of our courses are co-designed with Maori. So we have that content embedded in everything we're learning about in the social sciences and public health. So it would or being that I understand that most global health is being taught in European countries or America, where you don't get that Indigenous voice coming through like you do in Canada, New Zealand or Australia. It would be nice if people took that, they realised that they didn't kind of need to do that, because Indigenous models of health have different views and lenses to offer a more holistic view of health. And
Absolutely, yes.
so it's a gaze, but not through a.
Yes.
a
And I think it's so interesting to hear that in New Zealand it's been, because I know obviously at governmental level and institutional level, New Zealand has really pushed for the kind of co-leading by
Yes, because
inclusion of voices.
we are a bicultural country. That's
Yes.
part of the Treaty of Waitangi is that everything should be done
Yes.
collaboratively.
Yeah.
But having been studying in New Zealand, it's just completely embedded. You have to do it.
Yeah. Yeah.
But it's
Yeah.
really valuable because what I learned was because I'm so close to normal, is that everything feels like how I see the world is normal.
Yeah.
But when I'm forced to step outside of that and see something from someone else's point of view, I can then see that for them, every time they go into a classroom or something like that, they feel like they're uncomfortable because it's not their space. So the amount of comfort I feel walking into these positions is my privilege.
Maybe a VR set from their perspective that certain people can put on and
Yeah, we could do this collaboratively.
Absolutely.
Oh, and
We do have a sorry someone we do have a really inspiring Indigenous scholar who speaks every year to our students actually, and of course as you say there isn't such a tie with land here.
Yeah.
But it has inspired a lot of our students just from that one session actually. So it's really interesting point.
I think if we go back to your couple of slides, I mean, there is a big issue in terms of political propaganda, or politics in propaganda.
Yes.
You know,
Yeah.
because that is a very important element in global health education.
Yes.
You know? Especially the north-south divide.
Yeah.
It's all about politics and how to address it. That political sensitivity, which is rooted in imperialism, is really causing miseries to a lot of people around the world. I mean, we've seen America first, the damage they did.
Yes.
Immediately, without even thinking or reflecting, you know, Britain, Germany, Belgium, etc. All these countries cut their international budget without thinking.
Yes.
It's like a knee-jerk reflex.
Yes.
Without
The whole
even
sector,
calculating the damage. I mean, we sit in various WHO group and discuss this. What's going on? You know, we missed that politic because the current generation of people in global public health are ignorant of the big politics.
Yes.
Or they think that big politics is not important.
Dissociated.
And I'm really very sad for the huge number of fantastic colleagues in the United States. We lost their contribution to global health because they are prevented by politics.
Yeah.
So think about that.
In fact, one of the Fagati International Centre is one of the most kind of inspiring centres in terms of actually doing the things, the structural things that academic institutions can do. They train 6,000 international researchers with free scholarships. But I don't know what that's going to.
have they stopped working or?
I don't know. I haven't been able to find any updates on their funding.
Watch the space for the next pandemic, and you see we will not be able to respond because we don't have technical resources. We will not have actually financial resources to respond.
Yeah, absolutely. This is a
Way forward.
terrifying sort of coming
Current.
together. Yeah. Well, yeah.
Yeah, but we dream of world peace for the next
Ah.
10 years.
I'm in the New York now somewhere.
Yes, we need it. Absolutely, for sure.
You have to teach that actually, the politics of global health. It's a very important topic. Bring someone to talk about it. I mean, but this is a major topic for us, and we are discussing it at the global level with the WHO and other organizations.
Right, so it sounds like we need to do some more talking around that, because absolutely, I think for me that's very much linked to how we teach and the pedagogies that we approach it with. I think the definitions are such a good way to get into that already from the very start. Are there any other points on kind of
There's no comments on that.
envisioning futures? Thank you, Rachel.
I think for me, sorry, as you say, ideally, obviously we all have a special interest in global health, but ideally I'd hope to see it as more of a theme throughout medical, allied health professionals training,
Yeah.
rather than being a student sector component or a BSc. You're always going to have special further interest, but it really, for me, throughout my own lecture, is more of a tokenism or an assignment rather than a real central theme that runs longitudinally throughout all sort of health training. So that's
Yes. Yes. Yeah.
So that was what I was saying was the difference, because I've been studying in New Zealand, is that the indigenous models are embedded throughout your entire training. It's not just people who are going to go work in specialist areas. Like if you're studying social work or if you're studying nursing or doing public health in any form, every semester you are doing indigenous models.
and that's what ultimately leads to action. And long-lasting
And
action.
then the indigenous health practitioners have been involved in co-creating and delivering those models. I mean, it's not perfect. Don't get me wrong. There's still a
because the
massive
inequalities
gap.
are still there,
and
right?
inequality between the percentage of the population who are indigenous and the people teaching. Like there's a gap there. That's a problem.
Yeah, I think it's more about sustainability and providing a platform for all these organisations we work with, rather than it's where recruiting them to help us for a short period of time,
and
so they should be leading the education that we're doing across our.
Am I quoting you when I was saying that in the classroom sometimes it can be the work of the minoritized person to the lecturer turns and says to the minoritized person, do you want to talk on this subject? And then they become a subject of the class.
Yes.
Instead of,
I think you might be quoting one of our participants. Yes, that's right. Yes, and there was that tension of either being the spokesperson or somehow not being part of the
and
conversation.
also being seen as a homogenous
Yes.
group. So because you
Yes,
are,
absolutely.
Indian, you can speak from all the 4 billion Indian people
Yes.
across the globe.
Rachel, this is bigger than that, because it's truly, you need to believe in this, and there are a lot of statements supporting it. There are something documented in the literature, and we accepted it unbelievably, that there are people in the global north believe that everyone in the global south is not a human being.
Is not what, sorry?
Not a human being.
Yeah.
You know what this is?
Yeah, the
We are a human being living here in Britain, in Belgium, but the rest of the world are not human beings. And you know what happened in recent conflict, and statement made, etc., about innocent people killed, and some official called them. They are not a human being. But that genetically determined. You know what is genetically determined? Because people are raised on this concept. Because of my color, I'm a human, and your color, you are not a human. And unless that change, everything we are talking about in global health is really meaningless. Conceptually, that needs to change.
Absolutely, I think dehumanization has shown up a lot in global health debates around Palestine
That's why
recently.
I'm talking about the politics.
Absolutely, and I think that's very much in some ways, just like in many other fields, has very much delineated the difference between different perspectives, and very much global health as a field has shown up as not being on the side that stands up for humanization. So I absolutely sort of second that. Yeah. But I think part of the othering that students are describing in the classroom is very much that. It is that. It's different levels of that, but othering someone through language, whether you are doing it deliberately or not, is a part of, you know, placing someone in a further place.
But you showed in the slide one of them saying,
yeah,
them and us.
Yes, exactly.
No.
Yes, yeah. So students are now adding their voice to that. Not that there wasn't enough understanding of these questions before, but yeah. Okay, well, if we don't have any further dreams and visions for in 10 years' time, I will add a quote by Bell Hooks, which again infuses hope for me. Education is the practice of freedom, the means by which we draw up all that is good in ourselves and others to create a more humane world, and that very much reflects what we've just been discussed. And for me, my vision is also about me not being needed as a global health educator in 10 years' time. And again, I don't know if this is science fiction or not, although science fiction, it's definitely going to be science fiction to see myself in 10 years' time anyway. But the fact that actually the global health, the vast majority of universities in the global north are not necessarily needed, not the universities, but the courses that we're running, and the global geography of global health masters are not needed, not in that distribution. So it's also about kind of getting rid of the need to be teaching in the way that we are teaching. So I'm hoping that I've given you a sense of the kind of work that we do within my team. I hope that at the core of this, I think, is some of the claims that are being made about global health as a field more generally, not just about education. So global health isn't global, and we can see that from our classroom, as well as we can see that from all the other things that we've discussed today within the wider field. Curricular innovations that I've suggested today are useful. I see them as useful almost as a practice, as a reflective practice for educators, but also as a way to support and make better education in the moment. But they're not going to solve the tensions in the classroom, and they're not going to get rid of the inequalities in our sector. However, I do think that the idea that the classroom is situated within a wider world, and that there is a kind of two-way relationship there. So students are learning about the wider world, and the wider world is also influencing what happens in the classroom, is a really important one for anyone engaging in designing delivery curricula. And I'm excited about what can come out of the Global Health Classroom as well as an important site of inquiry, because what I think is going on here is that we've added, just in this discussion, we've added an insight in that students are sensitive, they're very sensitive to the inequalities that happen beyond the classroom, perhaps beyond even what I expected. So for me, this has been a story of finding my way to critical approaches to pedagogy through my students, and therefore I'd like to acknowledge my students past and present, including Ashani here, for showing up in the classroom, etc., and also for sharing a piece of themselves in research, and the undergraduate public health team for being such a supportive space to develop as an educator. Here are my references, and I'd like to say a big thank you to everyone here and everyone online for listening and for engaging, and also a big thank you to the WHO collaborating